Our study was rivaroxaban in patients with atrial fibrillation and a bioprosthetic mitral valve. The sponsor of the study was Hospital de Curaçao. It's a phase 2 multi-center non-inferiority open-label randomized clinical trial with concealed allocation and blind assessment outcomes. The objective is to compare the efficacy and safety of the gold standard warfarin to rivaroxaban 20 milligrams by mouth every day in patients with atrial fibrillation with a bioprosthetic valve over 12 months. The inclusion criteria stated that all participants, both male and female, must be 18 years or older so that they are able to apply legal consent to take place in the trial. They also must have diagnosed persistent or paroxysmal atrial fibrillation or flutter with a bioprosthetic mitral valve, but have had to be at least 48 hours post-surgery. Seeing as this is the disease state we are trying to treat, I feel this criteria is appropriate for inclusion. Exclusion criteria consists of 3 main categories. First, certain cardiovascular-related conditions as known presence of cardiac thrombus or tumor, such as an active endocarditis or uncontrolled hypertension. Second is hemorrhage risk-related criteria, such as an active internal bleed or increased bleeding risk. Third is conditions such as a history of thromboembolism with high risk of bleeding, anemia, pregnancy, breastfeeding, women of reproductive age, a creatinine clearance of less than 30 milliliters per minute, a known significant liver disease, or alanine aminotransferase 3 times the upper limit of normal. Treatment with chronic aspirin therapy greater than 100 milligrams daily, or dual antiplatelet therapy. IV antiplatelets, fibrinolytics, anticipated need for long-term non-steroidal anti-inflammatory drug, and systemic treatment with a strong CYP3A4 inhibitor or inducer. Previous participation in this study would also exclude you. Seeing as these criteria directly relate to contraindications of warfarin or rivaroxaban and are generally risk factors for the disease, I feel they are appropriate for this trial and do not need anything added.
The patients or their legal representatives were required to sign the informed consent. The study and the explanation of the study and informed consent was explained by the study coordinators and the physicians in charge of the study. Each patient was provided a copy of the informed consent, and the second copy was placed into another file containing the study documents. Patients were also informed that their participation in the study was completely voluntary. Any choice that the patients had to withdraw at any time, they were also informed that they would not be held accountable for that, and that would not affect the quality of their treatment or any subsequent medical care. Each patient was randomized by an electronic randomization system. The study coordinator was blinded to the randomization process, so they did not know who was going to what study treatment. Some patients were assigned to rivaroxaban and some patients were assigned to warfarin. Appropriate blinding was used. This was an open label study, meaning none of the patients were blinded to the treatment that they were receiving, and none of the study coordinators were blinded to that treatment either. An adjudication committee was established, and they were blinded after the study to analyze the data. This was to ensure that the data would not be analyzed with any bias in mind. The control was warfarin, and it was appropriate. Warfarin is the gold standard of anticoagulation in patients with atrial fibrillation with a bioprosthetic valve. Data was managed using an electronic data system. Case report forms were also used and sent to the study coordinator in a validation database. Data collection forms were password protected and signed electronically. Patient identification numbers were assigned, so no patient information was given. If any pertinent medical information from a patient's chart was included, that information was kept sealed and locked in a filing cabinet. There was a data safety monitoring board, and that oversaw reviewing the progress reports, efficacy, and safety reports of the study. The Data Safety Monitoring Board was made up of third-party reviewers. It was a biostatistician and 2 clinical investigators. They were to report their findings to an executive committee. Their main role was to monitor the safety of the patients throughout the trial. They could decide at any point if in the study it poses a hazardous risk to the patient that the study can be discontinued. The primary outcomes were defined as the time free of an event until the time up to a major clinical event within that 12-month window. A primary event would be a major clinical event in 12 months. So that could be a stroke, a transient ischemic attack, major bleeding, any cause of death, valve thrombosis, systemic embolism, or hospitalization due to heart failure. The secondary outcomes were major bleeding, or that would be any bleeding that produced a fatal outcome that involved a critical site or a fall in the hemoglobin concentration. The combined endpoint of non-fatal stroke, transient ischemic attack, systemic embolism, valve thrombosis, VTE, and vascular causes of death, they were measured using at the end of the trial. The sample size was not calculated because this was an exploratory trial. The data was simulated by deriving probabilities of increased relative risk to determine the sample size. A power of 80% was determined in favor of rivaroxaban when measuring the restricted survival mean time. This measures the superior survival rate between the rivaroxaban arm and the warfarin arm. An 80% power for the non-inferior test, which favored rivaroxaban, would prove that the sample size, which was 1,000, would be appropriate. The power of the test was determined by the simulation based off of the Rocket atrial fibrillation study, with a sample size that matched. For subgroup analysis, primary efficacy of the treatment was analyzed in different groups. So it would have been ages less than 65 or greater than or equal to 65, male or female, the amount of time since the mitral valve was replaced, whether it was less than 3 months, over 3 months, or over 8 years. It was also analyzed with creatinine clearance that was measured using the Cockcroft-Gault method. And INR in therapeutic range was measured for the warfarin arm. All of these statistical tests were appropriate for optimizing all the data that was generated that represented the respective outcomes of this study. So that would have been the time until a primary or secondary event was measured, and that was measured with the Kaplan-Meier survival curve. Treatment efficacy was measured by Cox regression, and the measurements were reported as hazard ratio. Relative risk reduction and number needed to treat were also measured. All of these tests were conducted with a 95% confidence interval and a p-value of 0.05.
So the results of this study was there was 1,005 participants. There was no patients that withdrew consent. However, there was 12 months of data missing for 6 patients due to their lack of follow-up. The baseline characteristics were well balanced between the groups with a higher overall female patient population. So the endpoints for the primary outcomes in the rivaroxaban group, there was a mean time of 347.5 days before a primary event was recorded, and there was a mean time of 340 days, 0.1 days for the warfarin group. There was a calculated RMST difference of 7.4 days between the primary outcomes between the rivaroxaban over the warfarin. In the development of the primary outcome for rivaroxaban over warfarin, it was found to be statistically significant for non-inferiority with a p-value that was less than 0.001. The development of the primary outcome of rivaroxaban over warfarin for superiority was found to be statistically non-significant, having a p-value of 0.10. The clinical significance for secondary outcomes of death from a cardiovascular event or thromboembolic events occurred in 17 patients taking rivaroxaban versus the 26 patients with the warfarin group. The incidence that occurred for the total stroke was 0.6% in patients taking rivaroxaban compared to 2.4% in patients with warfarin. Valve thrombosis occurred in 5 patients with rivaroxaban and 3 patients in the warfarin group. There was no statistical significance between the two groups regarding small bleeding chances. However, there was safety at 12 months with major bleeding events that occurred in 7 patients in rivaroxaban and 13 in warfarin.
In conclusion, the patients with AFib and bioprosthetic mitral valve rivaroxaban was non-inferior to warfarin with respect to the mean time until the occurrence of major clinical events. The authors did a great job with this study and the results. The data has been previously limited, and bioprosthetic valves have been a gray area. In the previous Rocket AFib trial, they didn't even use the bioprosthetic valves. In the Aristotle trial, there were only 31 patients. That was comparing apixaban to warfarin. In the Engage-TIMI trial, or Engage-TIMI 48, there was only 31 patients, and that was edoxaban compared to warfarin. In the River trial, we had 1,005 patients, giving us much better data. The limitations on this trial were that it was open label, so investigators and patients knew which drug they were taking, they knew the side effects, so that data could have been skewed. We tried to offset that by blinding the analyzing investigators, as well as training and monitoring at all the clinical sites. And for warfarin, because it's going off of INR levels, it was only in therapeutic INR 65.5% of the time, so it really is not a good comparison, because if a patient's taking rivaroxaban, they are in therapeutic at correct dosing. The strengths of our trial was the population size compared to previous trials. We had a great female population, which is hard to find in clinical trials, and rivaroxaban has less food and drug interactions. I would consider using rivaroxaban over warfarin in patients due to the INR levels, significantly better antiplatelet at baseline effects, and if it started within 3 months of treatment, it's much better for the patients. I wouldn't use rivaroxaban in cases of kidney functions, or if the patient is obese over 50% BMI. I would use warfarin, and I also would not use rivaroxaban in the Asian population, just because the population size of Asian patients was so small in this trial. Thank you.